Good morning, Ms. Barami.
Good morning, my lord. Our first witness this morning is Mrs. Emma McConnachie. She's a podiatrist in private practice and also a media and communications officer for the Royal College of Podiatry. And Mrs. McConnachie's statement reference number for the record is SCI WT 0669-501.
Good morning, Mrs. McConnachie.
Good morning, my lord.
Very good. We'll just start. Be asked some questions by Ms. Barami. When you're ready, Ms. Barami.
Thank you, my lord. Please could you start by telling us a bit about your background?
Certainly. I've been a podiatrist since 2004. I set up my own business in January of 2005 and have run that now for 19 and a half years. In January 2021, I joined the Royal College of Podiatry, or the College of Podiatry as it was then, as Media and Communications Officer, and for 4.5 years prior to that I was a non-executive director with the organisation, known as a council member. But I've been involved with the organisation since graduation as a volunteer as well.
Thank you. Now, your business is as a self-employed sole trader.
Yes.
What was your podiatry practice like in terms of structure and the cases that you treated prior to the pandemic restrictions being put in place?
So, despite being a sole trader, I do have multiple podiatrists that work within my practice, as well as an admin team. So, prior to the pandemic, this would have been, I think, 4 or 5 staff that we had podiatrists. We provided a wide range of different foot care services. It tended to be people who had difficulty accessing their own feet, needed assistance with different things, those who failed to meet NHS criteria or chose to go a private route for speed, convenience, anything else. So we would deal with people who just needed simple foot care needs, such as difficulty managing their own health, right the way through to more complex issues where somebody maybe had lost the feeling in their feet or the circulation in their feet. We perform minor surgery, issue antibiotics. We've got quite a bit like being a dentist, but just to say for the feet. We tended not to see anybody that needed very complex wound care or anybody who maybe was exceptionally high risk, because they would have usually been seen by the NHS podiatry provision. So.
Okay, thank you. And as the once the pandemic restrictions were put in place, I understand you had problems accessing medical supplies.
Yes.
Could you tell us about that?
Of course. We had difficulty accessing several types of supplies. The most prominent one was personal protective equipment, or PPE. We had restrictions placed on us quite early on. I'd say approximately a week before lockdown came in, some suppliers chose to stop supplying to the private sector in order to honour their NHS contracts. Now, as we use the same PPE as the NHS, this did make supply a little bit trickier. Throughout the pandemic, sort of the heightened period, this continued, and then slowly things would ease off. At first it was just PPE, then it spread to dressings and general medical supplies that we would have used in our everyday treatments. So we had to get quite creative sometimes. Amazon became one of my most reliable suppliers, sadly. So.
Did you ever have patients who needed dressings or other medical supplies that you just simply didn't have?
Yes, there was times where we didn't have the right wound care product that we would like, because we simply couldn't get the supplies. We would then have to think up alternative items that we could use. We had to plan quite far ahead as well for things. I mean, for example, nail surgeries. Typically, we would have maybe seen one a week or one every 2 weeks. At one point, we treated 10 nail surgeries in 1 week, which was a very stark increase. So I had to plan ahead, get supplies. One of my orders didn't actually come in, so I had to go to my colleagues in other practices to sort of beg and borrow, could we get ones, because orders were just failing to appear. The timeline that you'd be given would not always be accurate, so you had to plan quite far ahead and often order the same thing from maybe 3 different places to try and make sure it'd be in time.
Yeah. What were the delivery timescales, or was it that things still had to be produced then shipped, or was it just down to the delivery chain essentially?
It would vary greatly. Sometimes it was the supply actually coming into your supplier. You would be sometimes checking back twice a day to see if something had changed. I remember on one occasion an email went out from a supplier saying that a certain type of disinfectant wipe had come into stock, and within about half an hour it was sold out.
Okay.
Like, because everybody had just clicked that email and gone through, and that was it, with it being limited to, for example, 4 per customer.
Right.
Other times it would be a delivery was expected, it hadn't arrived, so your order would be put on hold, or it would just simply be cancelled and refunded. Other times it was you were given an expectation and you just got no communication as to when it was going to show up. It wasn't unusual to see an item might be a 4-month wait. So
As
it
long
just
as 4 months.
Yeah, it was very, very variable. But that was really, our suppliers also didn't have the information, and it was kind of changing all the time. I think that was probably felt across many sectors. But yeah, we just had to do the best we could with the estimates we were being given. So.
Yeah, thank you. Once the pandemic restrictions were put in place in the initial stage, how did your practice change?
It pretty much changed quite dramatically the Saturday before lockdown came. We read the Coronavirus Act 2020. We saw that allied health professionals that were HCPC registered could be called, drafted, conscripted into the NHS, at which point we realised there's very big changes coming quite soon. We cancelled all non-essential appointments at that stage. We took the decision, it was a collaborative decision led by me. We cancelled all of our non-essential patients. We brought forward anybody who we felt would be at risk if they weren't treated in the next few weeks, at risk of skin breakdown, ulceration or infection, and we offered them appointments on a sooner basis in anticipation of lockdown. I sent my non-essential staff home on the Monday. They were told not to come in, and then 8 p.m. on the Monday night we got word that lockdown was coming. So after that we couldn't treat anybody that was general care. It became urgent or critical care only. That would be if somebody had an open or active wound or it was life-threatening. Now within private podiatry that meant pretty much nobody. So for about 6 weeks we treated nobody.
Okay.
And it took a little while until we could start slowly increasing those number of people that we were able to treat. But it was a very sudden change for our business and our practice structure.
And in paragraph 30, you mentioned you could foresee what was coming because you'd worked in private healthcare during swine flu.
Yes.
Is that did that experience prepare you somewhat for this pandemic and to go to the to take the step of reading the Coronavirus Act?
When I worked during swine flu, we didn't have restrictions placed on us, but from my colleagues in the NHS, they spoke of preparedness within the NHS organisation. There had been talk of them being readied for mass vaccination. Our PPE classification changed, so it was now swine flu approved. So that gave you a bit of an insight into what was happening. I mean, infection control understanding as well came in. This was a coronavirus. It was expected to be transmitted by contact. Therefore, that meant we knew there would be restrictions coming on how we acted as healthcare professionals. So that teamed with what was happening in other countries around the world, being reported in the media, and the implementation of the Coronavirus Act.
Yeah.
We kind of put 2 and 2 together and came up with 5 and took the necessary steps that we felt necessary to keep our staff and our patients safe. So.
And you've mentioned that you had to cancel the routine work to prioritise more vulnerable patients. How did the patients whose appointments you cancelled react to that? Were they content and understanding?
Some were verbally abusive. They didn't understand. Some didn't believe that this disease was a threat and didn't understand why this would impact on their needs. As time went on, things became a little bit trickier when people were being cancelled, that they still didn't believe that their personal needs didn't meet the criteria. And everybody's pain is their own, and that was the worst pain they were feeling, which I completely understand, but in the larger picture, we just simply couldn't treat them. But yes, I was subjected to a reasonable amount of verbal abuse by patients, and some of those patients are no longer patients because of the way they acted towards myself or my staff at that time. So,
did you tell them that?
Yes, they were warned about behaviour, and then if that continued, they were struck from our books. But I'd say probably about 75% of our patients understood at first.
Yes.
As time went on, things did get a little bit more frustrated for them because they couldn't understand why they weren't allowed to still be seen. So,
Thank you. And in paragraph 33, you state that you offered general advice over the phone and by email.
Yes.
Is that something you also did prior to the pandemic, or
not in the same way. No, prior to that would have been maybe a little bit of general advice of, oh well, this is something that a podiatrist could treat. Come on in, and we'll have a look at it. You know, can give you some advice. Prior to the pandemic, I wouldn't have ever been prepared to give advice really from a photograph. We had to completely change our thought processes on what's termed remote consultations, where you would use video or photographs.
Yes.
We had to change how we triaged as well, because it simply became, it wasn't possible to see the person. So we had professional guidance that came out on this, and it was really an emerging area because it wasn't something people were really familiar with. Training your patients how to take a picture with a camera phone, for example, can be quite difficult. I got a lot of in-focus pictures of carpets and rugs and not feet. But those who weren't familiar with technology, it's very difficult to get an accurate description from, for example, an 86-year-old person who's living alone of what they feel their condition is.
Yeah.
You have to learn different language and terminologies to get a patient to accurately explain it to you. So it was a bit of a learning curve for that one.
Yeah. And you mentioned that you subsequently moved to start using video calling. Were your older patients able to use that technology, or did they need help at home with
Not
that?
just older patients, some of the younger patients as well. I think there's a general assumption that because of age you will be technologically savvy, and that wasn't always the case. So we would offer a video call, but it wasn't the only option that we would give. Those who were comfortable with it, they could have it. We would normally need photographs submitted as well, because I don't know if you've ever tried to get your foot on a video camera on a laptop. It's not an easiest thing. So we would have pictures, and we would have sent out a questionnaire or gone through questions with them as well. And the video call would be more to have a general discussion about the findings. If not, we would do a telephone call.
And with the video calls, if someone was able to get their foot within the image, within the shot, how did that compare to in-person consultations? You know, say in the best case when the foot was fully in focus and clear, did you feel as confident giving a diagnosis as you would have in person?
No, it was making the best of the circumstances available, but there's an awful lot of extra information that you would take in from somebody when they come to your clinic. When you see them in person, you would be able to see how they're dressed, what their footwear is. For example, you might notice that somebody's buttons are buttoned up slightly the wrong way. There's maybe some dried food on their top. Those could be signs that somebody's cognitive impairment has been altered, that their vision is altered. We'd be noticing the way that they walk into our clinic. You know, subtle little things that you would notice about somebody that might help inform the larger healthcare view. It's what we call more holistic practice. We're looking at the whole person.
Yeah.
So a lot of those things were lost. You would also lose the rest of the body when you're seeing it as well. So although I might be looking at an issue on your big toe, I'm also looking at your leg, you know, your other foot. You know, so many different parts. Often I'll also be looking at your hands because there's certain conditions that can come up in both. So this whole body picture was lost.
Yeah.
But say we would always let the patient know that this was based on the information available. So we had to sort of put that disclaimer in place as well.
Yeah, thank you. You state in paragraph 36 that in time when you had full day appointments, an appointment would be 30 minutes, then someone would have to spend 30 minutes decontaminating everything. So for every hour of work done, you could only charge for half the time. Did that at any point cause difficulties when it came to paying staff salaries?
Yes, so our podiatrists within my practice are all self-employed contractors. We took a collective decision when we started seeing patients again that we would only put our prices up very slightly. We put them up by £3. Some practices I know have had to put them up by £20 to purely cover the costs. Pre-pandemic, we were basically every 30 minutes we would be seeing a patient. So we would be back-to-back appointments. Then this became, we had to have this gap. You had to air out the room. You had to decontaminate absolutely everything instead of the usual surfaces that would be decontaminated. And that included our reception, our front door handle. Our reception team weren't able to return for the first 15 weeks. I had to furlough them. So therefore, we didn't have any manned reception area. We had to keep the door locked for security. There was also additional issues of you were then in a lone working situation, which you wouldn't have been in before. So we had to consider the security of that as well. But it did have a significant financial impact. It was something that we collectively felt we didn't want to charge more for at that time, because we also understood that many people had been furloughed or had lost their jobs and they didn't have the same income as before. So as a business, we absorbed as much of the cost as we possibly could for as long as we could.
And in paragraph 37, you say that by May 2020, you could do urgent work as well as critical work, and you had to deal with a backlog of patients, but you were far from working at full capacity. Is the reason you weren't working at full capacity that the backlog was small at that point, or is it just because of the time spent cleaning?
So we had a bit of a backlog because of the time spent cleaning as well. But in the first 4 weeks of lockdown, we cancelled 500 patients. So that was quite a significant amount to cancel. Prior to that, we would have 3 treatment rooms in operation. That wasn't possible under the new restrictions. We would often only have 1 or maximum 2 staff of a day, and we had to stagger when the patients were arriving as well. In fact, it was actually 4 years ago today, the 23rd of May, that we were able to start seeing urgent patients again, and that was then, we had to start triaging the calls that would come through. Prior to that, we had taken the 500 odd patients we had cancelled, and all the treating paediatrists had medically triaged them, because a patient's perceived level of urgency is not always the same as the medical level. So we contacted all of our patients that we had classified as high risk of breakdown to offer them appointments first, and we worked our way through, first of all based on medical need, and then based on date order, because logically the person who's had to wait the longest would be at the highest risk of a medical complication. Yes. And we also urged our patients, if they hadn't heard from us yet and they were in pain or had an issue, to please contact us to allow us to triage them sooner.
And the patients who didn't fall within the urgent or critical care category, were they also trying to make appointments with you at that point?
Yes, so everybody's pain is their own, and therefore, by comparison to other people, sometimes you have to make those very hard decisions. We did have patients not understand why their need wasn't the same need as somebody else's. We had some patients lied about their need to obtain an appointment, because they figured, well, once you've seen me and I'm here, you'll just do my treatment. So they were generally quite disappointed when we would refuse that, because they didn't meet the criteria. And we would have been at risk at that point. It was breaking the law. So we would have been at risk ourselves if somebody had reported us for treating something that didn't fall within the criteria. So yes, we had some creative things that would be told by patients to try and get in and get an appointment.
When that happened, where they lied about the condition and you had to refuse treatment, would they still pay for the time?
We chose not to charge them in that instance. I will clarify, at that point I wasn't actually able to treat patients. I was still shielding, but this is from my colleagues that were working for me at this time.
Yes.
But luckily it didn't happen too often. I do know anecdotally from colleagues in the profession, some had it a little bit more than others. But again, everybody could see different amounts of people and at different times as well. So we would have patients trying to register new with us from other practices as well, because their practitioners weren't able to practice during that time. So.
And do you think that the categories, the urgent and critical care, were appropriate in the circumstances, or do you have a view that all podiatry treatments should, preventative treatments even, should have continued throughout?
Personally, I feel it was the right thing at the time. It very much gave leeway to professional judgment, and I think that was one of the important things. It wasn't a very rigid set of rules. For example, you must have this disease and this disease in order to qualify. There was clear triaging advice was provided by the professional body to podiatrists, which did have, we had a judgment tree, like a decision-making tree, but it also relied on professional competency and judgment. If you felt that you could justify why that patient had to have treatment and it was important, you could, but you had to justify every treatment. Why did they meet this criteria to come in? So, say that really came down to your medical knowledge, your history taking, and your professional judgment as to who would meet those categories to see. But I feel at the time it was the appropriate thing to do with the level of risk that was perceived, by healthcare professionals and the medical experts at that time.
Thank you. And once the restrictions eased and services resumed as normal, had the lack of private and NHS preventative care led to more severe issues requiring more significant essential treatment?
Yes, we started to notice a big difference with what was coming in. Now, this could be something which might sound trivial to someone, for example, that they haven't had their toenails cut. The lower end of what we do as a podiatrist.
Yeah.
I have, for example, one patient, when they reappeared, there's significant changes in their feet. A fungal infection had developed. It had got quite quickly into their toenails. They've now been left with completely altered toenail structure, and that has led to ulcerative breakdown underneath their toenails as well. And that's an elderly person who lives alone. That has completely changed their risk category now.
Yes.
It's something that couldn't be foreseen at the time, but that had come up. We also had other people who were leaving it far longer than they ever would have. So say things like ulcers under toenails were common, other wounds that would have developed, or just even basic foot care issues that had gone too far because they hadn't been able to have the intervention that they might normally have had. But there was a wide and varied presentation that came.
Would ulcers under the toenails affect mobility?
Yes, it could be quite painful. And people would come in thinking that they had, for example, an ingrown toenail, and instead we found wounds actually underneath the sort of the nail bed instead. But we'd also had a lot of more complex things that were coming in. Not that these weren't things that we were able to cope with. Our training's the same as the NHS, our professional scope is the same, but people who were experiencing backlogs from the NHS care and they were now having to seek out private care. And this was something that financially they hadn't been used to as well. They had been in a privileged position where the NHS had been able to provide their healthcare free of charge, and all of a sudden they're faced with having to pay for that service. And that came as quite a shock to some people as to how much private healthcare actually costs as well.
And that was due to the increased demand on the NHS from these
My
worsened
NHS
cases.
colleagues were often redeployed to become district nursing services and not provide the same level of, the same type of care, the same provision of care as pre-2020 offered. So there were some significant changes. Some also ended up going on to become vaccinators as well. So that redeployment completely changed what was available within the NHS service provision.
Thank you. And did the lack of preventative care cause health conditions which affected life expectancy or gave rise to the need for palliative care?
Within my own profession, I would say not that I noted. I can tell you though that our patients coming in, some of them had not sought medical help for certain conditions. Therefore, certain life-altering and life-changing conditions had gone longer before treatment or diagnosis. So that in turn had a knock-on effect. We would see people who just didn't want to bother the doctors, or the perception they couldn't get a medical appointment, so they just didn't try. And that, say sadly in some situations, did have a knock-on effect. So it wouldn't be unusual for some of our patients that they hadn't seen anybody in healthcare for up to 18 months. By the end, they were just so scared. Even the panic attacks that we had from patients, we were the first people they had seen, and they would have panic attacks in our clinic because this was the first time they'd been out.
Fear of contracting COVID or fear of seeing people?
Fear of people, fear of being out in the world again, fear of contracting COVID. We would get a lot of questioning about our infection control procedures, what would we be doing for that. We did try to prepare our patients as best we could through detailing what we would be wearing, pictures of us, videos, even our patients that have learning needs and additional needs, we had to take that into consideration. We put in extra things in place for people with dementia, because if you have dementia, seeing somebody in a mask and a visor is a very scary thing. So we had pictures of ourselves up smiling, saying, for example, I'd have a sign up, me smiling without my mask on, saying, "Hi, I'm Emma, I'm your podiatrist, I'm treating your feet." And we would have that sitting beside us so that that could be there, and they would have a positive visual cue, because they had no body language to pick up on at all, which could make them more agitated and would have a negative impact on their treatment.
And in respect of conditions such as diabetes, did the lack of preventative care lead to situations where amputations became necessary?
Within my own practice, we didn't have too many that we were having to refer on, because critical wound care was still happening, and the lines for wound care within NHS podiatry were still open. But we did have some more patients who were perhaps struggling with their own personal control of certain conditions. And again, this can make things a little bit trickier when they're not as comfortable engaging with their healthcare professionals, or feel that they are not as important as other things that are going on in the world. Within the wider population, I don't believe there's any published statistics that have been made available to me at this time that I could comment on. But see, some of these things, you know, it's complications. It might not just be COVID, it might be other complications that arose during that time.
So you had a situation where some people had very trivial issues and were greatly exaggerating them to be seen ahead of others that had a greater need. And then you had people who had significant issues who had picked up the message that they should just not bother anyone and stay at home.
Yes, we had some patients as well who weren't willing to travel to us for appointments, that they would have an appointment and they just simply didn't come because of for example, the announcements around travelling. They didn't particularly understand that it was okay to travel for medical appointments, that even if you were shielded, you were still allowed to come out for medical appointments. So we would reinforce this in our reminders, and we implemented email reminders as well, which clearly detailed this. We did have some patients were stopped by the police as to why they were travelling, and this helped reinforce that they were crossing county lines to attend a medical appointment. But yeah, we did have a little bit of just not quite understanding that medical appointments were safe to travel to. And these sometimes sadly were left out of the communications from the government around healthcare appointments. It just didn't get mentioned sometimes, so it created a little confusion.
Are you aware of private podiatrists making home visits during that time?
So domiciliary or home visits were still permitted during certain circumstances, wound care in particular, but there had to be a very set, restriction in place. What's called the donning and doffing of your PPE, where you put it on. Some would have to do it on doorsteps and boots of cars. There was a very set procedure that you would have to follow. Podiatry isn't something that you can do a doorstep drop-off of. It's not like you could leave the prescription on the doorstep. You physically have to touch the person and treat the person, and that would mean entering somebody's premises. We don't do domiciliaries within my own practice, but I say I have many colleagues who were doing this. Some of them, though, did not feel comfortable doing it. It was a big ask. You're asking somebody in healthcare to put themselves into somebody else's home during a pandemic. Some just didn't feel comfortable doing it. So the onus, certainly for private practitioners, was it's only within your own comfort level what services you choose to offer. Those within the NHS, they were still working throughout, and their protocols would be changed by their employer. So.
Yeah, thank you. And you've mentioned there being more serious conditions. Was there a rise in the need for emergency care? And did that impact the private podiatry sector too, or just the NHS?
Yes, well, we did see quite a rise in things that were a bit more urgent, generally because people had left it. They'd ignored it, and then they couldn't ignore it anymore. So things like, we did have an increase in the amount of minor surgery that we were carrying out, specifically for ingrown toenails, because people had tried to fix it themselves, which does not end well, generally, or they had just left something. And then by the time they presented, there was no other option but to do surgery because it had just gone too far. Or again, they had ignored an issue that maybe should have been seen a little bit sooner, ordinarily they would have, and it had broken down to the point where you're going, okay, this is now wound care, this isn't our general care, you now need active wound care. And that can take a few weeks to heal. So something that could have been one treatment to fix it then becomes 6 treatments. So that then adds to your knock-on effect for your backlog as well, because you're having to find more appointment spaces for this person. So yeah, it's lots of little things, but could all add up into one bigger thing.
Yeah, thank you. Was your role at the college affected during the pandemic?
So during the early stages of the pandemic, I was a non-executive director at the college, and this meant that I was on the strategic direction. This changed quite significantly for me, so I was then involved weekly in what we termed the COBRA meetings, where all of the management team would come together to discuss the changes that would come in. There was quite a lot of emails flying backwards and forwards as well, lots of extra meetings being sorted, which I was dealing with on top of running my own business from home, because I had all my clinic phone lines diverted to my mobile. So on top of the 7-day-a-week working for my clinic, trying to deal with all my staff, I also had being asked for my professional opinion, being asked for my opinion as a business owner. And the college was very keen to speak to people in all different sectors within their network to try and make sure that their members' needs were being appropriately dealt with. I was also very active on professional forums, so I would often have people see me, rightly or wrongly, at the college and reach out to me looking for help. So I would have roughly about 100 private contacts a week from people desperately hoping that I had some kind of insight information. I remember at one point somebody actually asked me what the Chancellor thought on something, which was Mr Sunak at the time. I did find it amusing. They thought I had a personal phone line to Mr Sunak, but no. But they actually expected that level of information. So there was an awful lot of work to reassure and to communicate, because we had 10,000 very scared people. People who thought their livelihoods were going to be lost, people who didn't know if they could go to work next week or what would be happening. And any time there was a government announcement, I would get this flood of people asking me, looking for insight or a tidbit of information on what was going to happen.
If you had uncertainty about what certain guidance meant, was there someone that you were able to contact within the body that issued the guidance?
So within the Royal College of Podiatry, we have what's called a professional support team, and those are people who help issue our clinical standards and professional standards that we work by. So they were worked off their feet, no pun intended. They were working exceptionally hard to try and make sure that the guidance was as clear as possible. A typical timeline for them would be that new government guidance would be released at, say, 12 o'clock. They would be working till maybe 8 or 10 o'clock at night to make sure that this was clarified, that everything was understood. It would run past several people in the organisation, and it would perhaps be on the website by between 8 and 10 p.m. at night to make sure our members had access to this as soon as possible. And it's one thing I'm personally very proud of the staff that were working at that time for the dedication that they put in. And as a director of the organisation, it made me so proud to see the work they put in, all the overtime and the dedication to try and make sure that our members could do this, that they could help as many people as possible in as timely a manner, because it was a lot of extra work for them to do that, and outside their normal hours as well. So.
Thank you. Could you tell us a little bit about the financial impacts of the pandemic on the private podiatry sector?
So it was quite significant. We have private podiatrists are set up in many different ways. They could be sole traders like myself. They could be set up as limited companies, partnerships. This is where the furloughing system became slightly tricky. So if you were set up as a limited company, you would generally be an employee yourself, you'd be a director, and you would have to make the decision of, did you continue on or did you accept furlough? If you accepted furlough, you would not be able to contact any patients. It was the very basic administrative duties for your business you could run, which did not include speaking to patients. So you had to decide between putting yourself on furlough to receive an income to support your family and your livelihood, or providing patient care at significant financial detriment to yourself. Within my own scenario, I was a sole trader. I also owned a limited company at the time, which operated in tandem. But I was eligible for a self-employment payment, which was 80% of my earnings over a 3-year period, and that was the 3 tax years. During that time, I had actually been pregnant and on maternity benefit, which was the equivalent of statutory maternity pay, so that brought down the level I was able to get. So, like many other self-employed people across the country, you were given 80% of your average earnings for that 3-year period. I was still able to work during that time, which was or for part of it when I wasn't shielding, which allowed me to supplement that income. But for those podiatrists who were having to make the decision in a limited company basis, that was a very difficult decision for them. It wouldn't be unusual that you would pay yourself minimum wage and then see what earnings you could pay yourself as dividends at a later period based on the performance of your business. So if your official salary was minimum wage, that you got 80% of that. And that had a significant financial and well-being impact on many private podiatrists who had chosen to set up their businesses in that way. But we didn't get much in the way of financial support. Many businesses didn't. We received one £10,000 grant as a rates registered business, which was taxable, so that was £8,000, and that was the extent of the financial support that we got as a business. So despite rising costs, we had to figure out how to cover all of those. So.
Thank you. Could you tell us about the childcare issues that were particular to podiatrists in private practice?
So when the key worker and frontline healthcare worker sort of provision came out, key workers were classified into 3 sections, 1, 2 and 3, 1 being the most important. NHS podiatrists were classified as key worker level 1 because they were NHS employees. The private sector was classified as key worker level 2. So in certain scenarios, this meant that we couldn't access childcare provision. If a childcare facility only has 50 spaces and has 200 applicants, it's right that they triage. They have to give priority to key worker level 1. But it did mean that some of my staff in particular, my colleagues, did not get access to childcare. That then impacted on their ability to provide care to others and their ability to earn a living as well, because you cannot take your children to work in podiatry. It is completely inappropriate in that situation. If you're working admin from home, you can figure out ways around it, but you simply could not take your children into a clinical setting, pop some PPE on them and told them to sit in the corner and watch a film. That couldn't happen. So.
But your view is that distinction between NHS podiatry and private podiatry was justified?
I understand why it was taken, the perception that we were not doing the same critical level of work as our NHS colleagues, but we had been asked to stay open. We had been asked specifically to support the NHS by providing access to our services, and that had an impact. My own situation, both my husband and I are healthcare workers. We both work in the private sector. Neither of us qualified in the first instance. Then they had spaces opened up. Schools had to look at, if you've got 2 people that do it, what could this do? Where grandparents or family members might have previously been able to provide support, they weren't allowed to. So, you're asking your family to break the law to look after your children so that you could go and help other people. And these are just the wee things that, would have an impact. But I appreciate it was an emerging situation, and, it's different looking at it in hindsight than it was at the time as well. So.
Yes. Thank you. In paragraph 70, you state that you have rheumatoid arthritis, the treatment for which leaves your immune system vulnerable, and accordingly you shielded from April to July 2020.
Yes.
Did you decide to shield, or were you placed on the shielding list?
I had to decide to shield myself. I didn't receive a shielding instruction in the first few waves. As a healthcare professional, I am aware of what my medication at the time did to me. I was on a medication which severely suppressed my immune system. The communication that was coming out from the government on shielding was, if you have one of these conditions, you shield and you wait for your letter. If you do not receive that letter, get in touch with your GP. I didn't receive that letter, so I had to get in touch with my GP, at which point I was reviewed and placed on the shielding list. But yes, I knew from what was being said that I was very highly susceptible to catching COVID, and therefore shielded myself from the public.
How straightforward was it contacting your GP and being placed on the list? Was your GP quite accepting of that?
Yes, they were quite accepting. I highlighted that I felt I should have been receiving a shielding letter and hadn't. I received a call back and I was asked some questions as to why I felt I should be shielded. They agreed and they put it through, I think it was called a Schedule 7, where the GP can choose to place you on the list. It transpired that the advice for original, the first few passes of shielding, was that if you had rheumatoid arthritis, you must be on 2 disease-modifying anti-rheumatic drugs, known as DMARDs, and I was on 1, which was a bit more unusual. However, if I had been on that same drug from a dermatological viewpoint, I would have been shielded on 1. Okay. That advice, again, an emergent situation, the advice changed as time went on, and I would have received a letter probably a couple of weeks later anyway. My specialist advised me, oh, they did then change that, the professional bodies reviewed it, and I would have been called. But yes, the rheumatology department had a very large number of people to be looking after as well, and trying to make sure that everybody was supported.
Thank you. And in May 2022, you contracted COVID and required hospital treatment.
Yes.
Please could you tell us about your experience of accessing medical care and being treated in hospital?
So it was actually 2 years ago today. I was taken as a day patient to Forth Valley Royal Hospital in Larbert. The previous day I had tested positive for COVID in the evening. I had written notification in advance of this, should I ever contract COVID. Here was a local phone number to call for triaging. I called that morning, so I think it was a Sunday night I developed COVID, and I called them on the Monday morning, and within about an hour I had a call back to triage my symptoms, and I was asked to have anybody that could actually bring me to hospital safely, and I was seen at hospital a few hours later, and I was dropped off at a door, escorted by PPE clad staff into an isolation unit. I was consented for an antiviral treatment by intravenous method, including that it was experimental and there was a chance of death if I took this. And I was then placed on an IV for a few hours to receive antiviral treatment, not to make me better, but to stop me from getting worse, as they were concerned about the impact that me contracting COVID would have. By this point, I'd had 5 vaccines, and I was a month after my 5th vaccine. And yes, it was quite severe, the symptoms that I developed on the first day, hence they chose to give me an IV antiviral instead of oral antivirals.
And while you were in hospital, did you find the use of PPE and infection prevention and control measures all to be appropriate? Were you quite happy with those aspects of things?
I noted at the time visors I don't think were being used by that point, as in line with the infection control guidance at the time. It was 2R face masks, single-use aprons and gloves, which was all appropriate. I was in my own room. I didn't see anybody else on the way in. I was met by staff wearing PPE. I had chosen to wear a 2R face mask, an FFP2 face mask myself. For my personal circumstances, I preferred an FFP2 for the level of infection control and protection that it would offer people. I was also acutely aware I had a highly contagious disease and I was entering a hospital environment. So I had taken my own measures as well. But all infection control guidance that was provided to healthcare at that time was being adhered to when I was in hospital.
Great, thank you. In paragraph 78, you say that you were very impressed with the guidance from the Scottish Government while you were shielding. This isn't a sentiment that we've heard very often. Could you please tell us about your experience of receiving the guidance?
So I received regular letters, texts and updates on this. I work in communications now, so I felt that the communications that were received were quite clear. For example, when the First Minister would be making an announcement that was relating to shielding, I would be sent a text notification to alert me to this, to watch the television at that time, which I felt was quite forward thinking. I didn't then get caught unawares on the TV that something had changed. I felt the guidance that came out in writing was clear and to the point, contained frequently asked questions that I felt explained things clearly. I received a Christmas card from the First Minister at the time, which also contained some shielding advice as well. But I did feel that the guidance coming out answered any questions that I would have and made it quite clear what I should and should not be doing in certain circumstances. My friends in England who were shielding would often contact me to ask what I had had, because they didn't feel that what they had had was particularly detailed, and that's their personal opinions on it. And I would share with them photographs of what I had had, and they'd go, oh, well, that makes that quite clear. Some of my friends chose to follow the Scottish advice that were shielding in England as opposed to the English advice, particularly when the stay alert moved. So it changed from stay at home to stay alert, and they did not feel personally safe as people in the shielded category with the new guidance, so they chose to follow the slightly more restrictive Scottish guidance because they felt that that was more appropriate for their personal comfort level with their risk.
Thank you. And can you tell us, once shielding came to an end, how did you find the transition from shielding to being back at work? Were you concerned for your safety, or?
Yes, it was absolutely nerve-wracking. I've worked in healthcare, say, since 1999, but all of a sudden I was being faced with people who didn't know how to wear PPE. I've seen more noses on top of masks than I knew what to do with, having to constantly ask patients to actually put their PPE on properly, making sure they actually washed their hands as well when they came in, or used alcohol gel. A lot of people felt it didn't apply to them. It was quite nerve-wracking being faced, with this constant stream of people who could, as I believed at that time, potentially kill me. But I was having to go and still treat them. You're putting yourself at risk every single time you have that patient contact. I had control of my own PPE, which I felt made a big difference for me. We chose to go a mask level above. We were advised a 2R mask would be all that would be required in healthcare. We chose to use an FFP2 because we are in a 30-minute appointment in an enclosed room with somebody. Again, you'll have people maybe would sneeze, they would take off their mask to sneeze and then put their mask back on again. So even with my FFP2 mask and a full visor, you were making sure the room was being aired out because there was particles in it. And I'm looking at their feet the whole time, I'm not looking at their face. I would sometimes look up and spotted they'd taken their mask down, and you're having to say to them to put it back up. We also brought in screens as well, which we had to make ourselves, which were acetate suspended on a frame, which we would place over the patient chair so that the feet were with us and there was a screen between us and the patient, which provided an extra level of protection, again, for when the sneezes and the masks being removed were there. We did, of course, have some patients who were mask exempt for medical reasons, which was completely understood and respected within our practice, but that gave us an extra level of protection from that. But yes, it was my heart was racing the first time I went back in, which when you're wearing a fully face-fitted mask was quite a thing. I'd regularly be bruised by the end of the day, so I would have bruising across my nose. I had to take to wearing a skull cap, covering for my hair because my visor was taking chunks of my hair out as well. And I had to wear special strapping to keep the mask onto my face. I have a very small face, and masks are made for the average 70-kilogram man. They are not made for women of my stature. So trying to find masks that would fit my face was quite difficult. So I would have to fold my mask to make it fit my face, and I would have to strap it tightly around the back of my head because if you didn't have a full seal, it didn't work. So,
how long did it take before you were back to your pre-shielding comfort levels around people?
I'd say probably a few months. Even when I was back in work, of course I had on PPE the whole time. We staggered our lunch breaks. We didn't eat lunch together. If there was ever a time where two staff members were on lunch together, one would be in our staff room, our back door would be open to ensure free flow of air, and another person would be sitting in the corridor. We had 2 metres between us at all times. Within my own practice, no staff members contracted COVID for the first 2 years of the pandemic, despite being frontline healthcare workers in constant contact with people. We had no staff cases at all. And I like to believe that's because of the measures that we were taking and our understanding of infection control. We were cautious outside of the workplace as well, because you had that knowledge if you got COVID, you were out for 10 days at least, and the impact that had on your patients, that was 10 days you couldn't provide patient care. So we were all exceptionally careful during that time.
Thank you. You state in paragraph 86 that your son's autism diagnosis was delayed because of COVID.
Yes.
Could you tell us the impact of that on your son and on your family?
So my son turned 3 in February 2020 and started education, nursery, 10 days before the pandemic really hit and lockdown was announced. He hadn't been in formal education settings prior to that, so this was really, I would have said, the first opportunity that any learning differences and social differences would have been noticed. And we lost all nursery after 10 days. He had 5 months where he saw no other children, and he was with only myself and my husband. This changed any level of tolerance that he had already built up. So when it then came time to re-enter nursery, which would have been August 2020, he struggled quite significantly with that. The noise of people, he has sensory issues, which again we hadn't noticed prior to that. During that time, he was found crying in a cupboard because he was so overwhelmed with the sound and the amount of people. He had lost many social skills during that time, as had many other children as well. He's an only child, so he didn't have any other children to play with. Because of the impact of the process where we were all having to stay away from other people, so many children developed issues with interaction. They missed key stages. The developmental markers all changed. Yes. Therefore, so many other children were also nervous of other people, were also experiencing things in a different way, that it wasn't really picked up on in the same way. His educational psychologist, he was assigned through the school, didn't see any issue at the time. It was here's some things we can try. Wasn't until he actually started primary school. He's currently in primary 2, so that would have been 2022. He started primary school. Even with an enhanced transition, he really struggled in the first week, and we were still not offered a CAMHS referral. We ended up having to go privately to seek him help, and he was found to have significant needs. He is autistic, he is most likely ADHD, which is being confirmed at the moment, and suspected dyspraxia as well, and is in the first percentile for motor function. So whilst he has learned to cover all these things up very well and is a very happy little boy, and his school has provided many, many wonderful ways, and their support has been amazing, there are many things that could have been picked up earlier, but because so many other children were experiencing a whole new set of issues, you know, there just wasn't the service provision there to help with it. So at that time, I believe we were told it would be a 4-year wait for CAMHS and for any form of formal diagnosis, which would have had a severe impact on his ability to form social connections and receive an education. Hence, we chose to go the route that we did for him. So.
Thank you. Going back a bit in your statement, in paragraph 60, you state that the Scottish Government made it clear that all healthcare workers should be provided with the vaccine, but in practice it didn't work out that way. No. We've heard from others that they believe, their experience was that the issue came down to the lack of an NHS email address to book a vaccination appointment. Is this an issue that you faced as well, or in your experience, was it limited to what you say in paragraph 62, that the NHS-based delivery team for the vaccine didn't realise what was included in private healthcare?
I think, for my personal opinion, I think it was a lack of understanding from those who were actually faced with creating the service delivery plan. So the guidance from the Scottish Government and from all the UK devolved nations and England did say that it was for all frontline healthcare workers, private, independent, third sector, so charity, as well as the NHS and social care. In reality, when you were trying to access this, those numbers and those access points were distributed through an NHS intranet. They were distributed to social care providers. It was like gold dust trying to find that phone number. When I did find it and called it, I was told, well, you're not eligible, you're not NHS. Go through your department head. I am the department head. Well, go to your occupational health. You are my occupational health. Now, this had been something I'd experienced pre-pandemic, even trying to access a flu vaccine. I would have to go to my GP practice to be told, you have to go to your occupational health. You are my occupational health. And it would be a standing battle every year for this. But it became quite apparent, say, during this time, my staff, my team, were being actively refused access to a vaccine because we were not NHS. We didn't have an NHS email or an ID. Even when we did eventually get access, we were told to bring our payslips, our NHS payslips or our NHS ID badges. I had to write all of my staff a letter. I had to generate them, physical IDs to take. We actually had to hire a company to make IDs for us so that they had photo ID to meet the requirements. And it was just an absolute uphill battle to be recognised as frontline healthcare workers. But see, I do believe that was just a simple lack of understanding that private healthcare isn't doctors and nurses in hospitals, that it is podiatrists, it is physiotherapists, it is audiologists, because opticians and dentists, who are often private, are NHS contractors and therefore had access to that. So, yes, it was I think just a general, you didn't know what you didn't know, and it just hadn't occurred to them. I don't think there was any maliciousness to it, it just hadn't entered the thought. And that did in time get corrected, but again, that was quite an uphill battle and varied from health board to health board, as each health board was responsible for rolling out their own access to it.
And following on from that, you also raised concerns about assumptions by government and other agencies that NHS is healthcare, and that other guidance not about the vaccine was only distributed through the NHS as well, and that created issues for those in private practice. Yes. Could you tell us more about that and the impact on the private healthcare sector and consequently on patients?
So as restrictions would change, the guidance would often change for healthcare workers as well. The guidance for healthcare workers was very different to the guidance for the public in some cases. This would be distributed to the NHS and to social care. The only way the private practitioners would be able to access it was if you happened to know it had been released, and you would find it on the Scottish Government website or your own government's website, or if you had a professional body that was telling you this. Now, I was very fortunate at the time. My professional body was part of the Scottish Unions Network, which was given these updates because there was a special COVID committee, I believe, that was formed. That committee disbanded, I believe in the past year or so, it disbanded. Therefore, the updates stopped. Now, I believe there was an update to NHS protocols for if you have contracted COVID about attending work. We've never been told that. So we're still operating under if you have, if you've been given COVID, if you have COVID, if you test positive, you have to be off for a set number of days. Whenever these public health guidances came out, sometimes I feel that the private sector was forgotten in that communication chain. But we are still frontline healthcare workers. We still have to have workplace protocols. And we see this in other sectors as well, in health and safety and things. It will be the NHS that is considered the healthcare providers. And again, your social services from council, your caring support, these are agencies, these are businesses, they have contracts for these things. So there is a line for this to be sent down. But if you're a self-employed practitioner, if you're running your own business, who do you have to tell you these things? You rely on a source of information. But if that source of information isn't being given it can be very challenging at times to make sure that you're fully compliant when there's this block on you getting things.
Thank you. Now, we have your statement and we'll consider that in full alongside your oral evidence today. Is there anything we haven't covered today that you would like to highlight or mention at this point?
I don't think so. I think we've covered sort of all of the bigger challenges around key worker recognition and vaccines and access to PPE and the general information that was coming out. So I don't think I've got anything else to add at this time. Thank you.
Thank you very much.
Thank you very much, Mrs. McConnachie. Very good. A little bit sharp, but we'll come back at 11:15 as scheduled. Thank you very much.
Thank you.
Lord.
Now, good morning, Mr. Edwards.
Good morning, my lord. The evidence of the next witness, my lord, is subject to a restriction order, and so the witness statement and the recording of the evidence are anonymised.
And that, yes.
Now, the reference for the witness statement is SCI WTO 921 5 zeros and a 1. Good morning, witness.
Good morning, Mr. Edwards.
Yes. Now, you are providing your evidence today, as I say, subject to a restriction order and anonymised, but you are agreeable for your witness statement to be published on that basis and for your
Yes.
evidence to be recorded on that basis, yes?
Yes.
Yes. Now, in your witness statement, which I hope you have a copy of in front of you, yes, or you can see online, yes?
Yes.
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 You explain that you're giving your evidence as someone who worked as a carer in a private care home and also as a union representative for the GMB.
Yes.
Yes. Now, you explain that you were employed as a care provider during the COVID-19 pandemic. This was your first job in the care sector. But you held that position for over 8 years, is that right?
Yes, correct.
And most of your evidence today concerns what you want to say about your work in the private sector, in a private care home.
Yes, correct.
Yeah. And the details of this are set out in paragraph 3 of your statement, where you say that at this time, from the beginning of the pandemic and through the pandemic, you worked in a private care home which had about 60 beds and was a nursing home.
Yes, correct.
Yeah. Now, if we just look at paragraph 3 of your statement again, you say a few words about how the work structure worked in this care home before the pandemic.
Yes.
So could you just summarise that for us?
So we had 60 beds. It was split into 3 different units. So you had 30 beds upstairs. You had one unit which was a younger adults unit and another unit downstairs that was a dementia unit. You would typically have one nurse in the building, and you should, for upstairs, have 3 or 4 care assistants, depending on if there was a senior care assistant on duty. Downstairs in the younger adults, you should have 2 people on at all times, and in the dementia, depending on how full the beds are, there would typically be 2 to 3 carers on shift.
Yes. Now, you also say in paragraph 5, just to set the trades union context, that you did have a union recognition agreement in place at the home, but no representative, is that right?
Yes, that's correct.
Yes.
There was no representative when I joined.
And I think you volunteered to be the representative, is that right?
I did, yes.
Yes. And did you actually become the representative?
Not officially, because I wasn't allowed to go on the training.
Yes. And then you do also you indicate that there was some effort by the home to de-recognise the union. This would be before the pandemic, would it?
Yes, correct.
All right, well, that sets the scene for the position at the outbreak of the pandemic, and you then turn to some of the initial impacts at the outset of the pandemic. So this would be around February, March of 2020, I think, yes?
Yes, correct.
Yeah. And you first begin by discussing how people began to see the developments and their initial concerns. So
Yes.
can you remember then when you first became aware of the emergence of the pandemic and fears about it coming to Scotland?
So obviously it was round about when it was in different countries. It wasn't in the UK yet. It hadn't started spreading or anything like that. Just wasn't here. Staff started to hear about it in the news, and then it just became like more regular every day. You were hearing more and more about it, and then you would hear about how COVID had started coming into the UK, and there started to be like rumblings at work about what would happen if the virus did come here, and people started to get a little bit scared about like obviously what would happen if it did.
Now, as many witnesses have said in different contexts, there were initially concerns about PPE and the availability of PPE. Now, interesting, at the end of paragraph 8 of your statement, you explain what the position was for you and your colleagues in the care home before the pandemic in relation to PPE. So what would be the standard sort of uniform in the care home, as far as you can remember?
So the standard uniform before the pandemic, you would have a pinafore, you would have PPE for if there was any infection control, like if there was any infection in the home, like norovirus or anything, you would have gloves, an apron, disposable aprons, and not that I'm aware that we had any masks or anything like that. It was just your standard gloves, apron, your bags to put infectious clothes in, and disposable waste bags.
Yes. So masks wouldn't be available.
No.
In the care home. Yeah. Now, with the outbreak of the pandemic, then in March or February, March 2020 here, what approach was taken by the management where you worked to PPE?
There wasn't great concern from management. They didn't really see COVID as a massive thing when it first started. And I remember that myself and some staff members were quite nervous that we didn't have any PPE. So I had taken it as like the unofficial union rep, taken it upon myself to go to management and speak to them about staff's concerns. Just letting them know that I think we need to get some masks in, and that staff are like concerned about contracting COVID-19, and that it's starting to become a bigger thing now. So it would be good if management could maybe prioritise that. And we got told that we were being dramatic and ridiculous at the time, and said that staff don't need it. But so I had said staff are wanting to wear their own masks and bring their own masks in, and they said, well, if they want to be ridiculous and dramatic, we can do that and wear the masks if they so please. So yeah.
So I think what you're saying, basically, to summarise, is that when you approached them, when you approached the management, there was some scepticism about the need for any further PPE compared to that which already existed.
Yes, correct.
Yes. Now, things did begin to change. I mean, can you remember the timeline of when things began to change? I mean, was it during March 2020, or was it over a longer period? Begin to change, I mean, the attitude of management to the need for PPE. When did that begin to change?
I would say that it was roughly before the first lockdown that's when it started to become a little bit more serious. Because obviously more and more cases were arising, and it was on the news every day, on the radio every day. So I think that then they started realising, okay, maybe this might become a little bit serious.
Yes, and in paragraph 11, I think you say, so this would be around about before the first lockdown, so it's sometime in March 2020. In paragraph 11, you say that management had asked internally for PPE.
Yes.
But it had not been received yet. When you say internally, what do you mean by that?
So they had asked HR and people that are above them about, because there's a chain of homes, so they asked them what they were doing in other homes and asked them what the measures were going to be in our home.
Yeah, but you indicate that one concern was how this was going to be paid for.
Yeah, they did. The management did mention a lot that there wasn't enough funding to get PPE, and that they could only really get what they were given, and they had to source more funding in order to be able to actually purchase the PPE that we needed.
So what you remember being told then is that the home itself wouldn't be prepared to pay for it, but there would have to be an additional funding source from someone else.
Yes, correct.
Now, one way or another, the PPE did arrive. and this is when masks first appeared on the scene, as you remember. Is that right?
Yes, correct.
And the masks that initially arrived were the blue surgical masks, I think you say in paragraph 12.
Yes, correct.
Yeah. But there were then some issues with access to the surgical masks, is that right?
Yes, correct.
And I mean, I'll ask you to put it in your own words, but just to set the scene, what you're saying in the following paragraphs is that an administrator was put in charge of access to the PPE, and this led to some difficulties for access to the PPE by the night staff, because the administrator wouldn't be working during the night. So
Yes.
if we could just go over that a little bit. I mean, you talk about this in paragraphs 13 and 14 of your statement. But if we could just deal first with this issue about who was in charge of access to the PPE. So how did that work?
So the administrator had been told that she was in charge of allocating the PPE to the staff that were on shift. Typically I work day shift, so she was in charge of who would get masks and who would get any PPE. At first, when we tried to access like any PPE, we were told that we were using too much too quickly, so it started to get locked into the cupboard downstairs. So you would have to go to the administrator to ask for more PPE if you needed any more. We had single-use masks, so obviously staff were going up and asking for different masks through the day because they have to take it off and they didn't want to put it back on. So they would ask for more, and that sometimes was an issue trying to get it because we got told there wasn't enough PPE, there wasn't enough masks, so we had to keep reusing the masks. And then when it came to night shift, I had a really good rapport with night shift. I used to work night shift, and they were telling me that by the time that their shift had started, there wasn't any PPE available because the administrator wasn't actually on duty when they were on nights. So they had went home, the cupboard was locked, they didn't have any PPE. So it came to the point where care staff in the home and myself would have to try and hide some PPE so that the night staff were left with some.
So what you're saying was then it was other staff like yourself who were making provision for the night staff because the administrator hadn't done that themselves.
Yes, correct.
Yeah. And you're also saying, importantly, that there were issues about effectiveness of the masks because single-use masks were being, at this time, single-use masks were being used repeatedly.
Yes, correct. There was posters in the home at the time that stated that staff should not chuck out their single-use masks because there wasn't enough to go around, so we need to keep their masks on them at all times, which obviously concerned staff because they're single-use masks and it's not very hygienic either.
Now, in paragraph 15, you say you raised these issues. Now, just to be clear, are you raising these issues as a member of staff or as a union representative?
I was raising it as a member of staff. People were coming to me nearly every single day with concerns because obviously I was going to be the union rep. They felt comfortable enough to come to me, so I kind of felt like I was acting as an unofficial union rep. But my concerns solely were as a member of staff.
Mm-hmm. Because you weren't recognised by the management as the union rep, were you, at this time?
Absolutely not. No.
Now, I think you say that these problems continued during the first lockdown, or most of the first lockdown, so between March and July 2020.
Yes, correct.
But by the second lockdown, so later in the year, by November, the practices and offering, if I can call it that, of PPE changed.
Yep. Yes.
Yeah. Was that because of an availability issue? It became more available, or simply because the management of it changed?
I actually think it was because they started to realise the severity of the situation and refusing to give staff PPE when there was a COVID-19 pandemic going on and it was becoming very serious. I think they would have had bad implications of that. So I think they realised, okay, we need to actually take this seriously now.
And so what in particular... Sorry,
that's my fault. I apologise.
No. Sorry, my lord.
No, I apologise.
Just returning to this question of what changed during the second lockdown. So can you maybe summarise what you remember as having changed? So let me interrupt, sorry, there was more access, but what changed in terms of the availability for you and your colleagues?
Well, I think the government started actually recognising that care homes were needing PPE, so that was getting mentioned in the news quite a bit. We started actually getting more access to the boxes of gloves and the masks and everything. They came out of the cupboards, and we started to have PPE stations. Really, that should have been how it was from the start, but they started to stocking up the PPE so that it was actually more available to staff now.
Thank you. Now, in paragraph 17 of your statement, you make the point that at the care home, sanitizer became available as a result of donations.
Yes.
Yeah. So, I mean, are you saying that during the first lockdown, by which I mean the period March to July 2020, sanitizer wasn't routinely available?
It wasn't available. No, there wasn't enough to go around.
And so you seem to, you remember that there was, the availability depended on donations.
Yes, or staff bringing in their own sanitizer and sharing it amongst each other.
And then there were similar issues in relation to the pinafores, weren't there, about dependence on donations?
Yes, yes.
So given that pinafores were a routine part of the uniform before the pandemic, I mean, how did this problem come about with pinafores?
There wasn't enough uniform to go around, so we were told that we needed to obviously take our uniform into work, and it was to be washed into work. We weren't allowed to leave with our uniform on, but not a lot of staff actually had access to a second uniform, and we'd obviously raised concerns about that to management. We were kindly donated some pinafores, but there wasn't enough to go around, and they were also donated because they weren't fit for purpose for the hospitals, so they were donated to the care home. So staff would either have to come in with a t-shirt on and wear a t-shirt if they were working downstairs in the dementia unit, or they would have to then go and buy their own pinafore, so they had more than enough because their uniform wasn't always washed by the time they came in.
So the uniform, including the pinafore, was left in the care home and would be washed there,
Yes.
but it might not be washed and dried by the time someone came back to work the next day, for example.
Yeah, correct, because we obviously had so much residence clothes to wash, they sometimes would fall behind and not manage to get to the uniforms.
Yeah, thank you. Now, you then turn to the challenges of social distancing in a care home as you remember it. So, as you said at the beginning, many of the, not all, but many of the residents in the care home you were at were elderly and had dementia.
Yes, correct.
Yes. And when the social distancing rules came into force, there were particular difficulties in managing the residents in this respect, yes?
Yes, correct.
Yeah. So can you just explain what some of the difficulties were?
Well, we were dealing with residents that had dementia, so it's not always possible to, stop someone walking where they want to go. You don't want to distress them. You don't want to cause them any difficulties. So when management are telling us, oh yeah, you have to keep people isolated, they have to be in their rooms or they have to be separated, it's difficult to do because you didn't want to take away that person's needs, or we were trying to be as person-centred as possible. So these people are they're humans. We're not about to tell them they can't do it. They have a choice. So it was really difficult trying to manage that situation by trying to keep management happy, but also caring for our residents in the way that we should be caring for them.
So one of the issues I think you identify is that when the social distancing rules came in, the normal activities of people, being in the living room area of the home, for example, and engaging in activities changed, and people had to stay in their own room. Is that right?
Yes, that's correct.
Mm-hmm. And then it was up to carers like you to make sure they stayed in their room, yes?
Yes, correct.
As best you could, yes. And that means that all activities in the home stopped, by which I mean games and social activities stopped.
Yes, they did, yes.
And what about eating? How did communal eating then work in the dining room, for example?
So we were told that we had to separate people at the tables if they were to go into the dining area. Management did ask us to try and keep people in their rooms as much as possible to eat their dinner. Obviously, staff and I did not agree with that because that was the only time that the residents had to socialise, especially because some of them did enjoy socialising quite a lot, and it was the only day that they had to speak to someone. We didn't agree with what management were trying to get us to do, so sometimes we just went against management and would take people into the dining area, but just make sure that they were socially distanced, because we just felt that them socialising was really, really important for their needs.
And dealing with these challenges was taking place at a time when there were staff shortages because people were off sick, for example.
Yes, correct.
Yes. You also discuss in paragraph 21 various issues around visiting at the home. Now, of course, visiting inside the home would have stopped, but there were issues about some family members being able to come to the windows of the home and others not.
Yes.
And so how did that happen? I mean, was that just arbitrary or accidental or deliberate?
This was something that I was battling with management at the time. I thought that there was a lot of favouritism from management to some of the residents and some of the residents' family, mainly because some family members would maybe put complaints in if they didn't get to come and visit, so they were trying to keep them happy. So basically the ones that weren't complaining were the ones that were almost getting punished for not seeing their families because they weren't raising any issues. There was no consistency. It caused a lot of friction between staff, management and residents' family members. There was no clear communication on what the policies were or the procedures were for people coming to visit. It was just kind of, made up as they went along. We just got told, yeah, this person's coming to the window today, and then if we would ask for another resident's family member to be able to come and visit us, oh no, sorry, we can't, it goes against guidelines. So it was really inconsistent.
And then at the end of this section, you address the issue of training, that there was some basic COVID-19 training offered. Now, what would this training have covered?
So it was e-learning, so it was just about infection control, what PPE we should be wearing, the impacts of COVID-19 and the symptoms. It was your very basic e-learning training.
But you had to do this on your own at home?
Yes, unpaid.
Right, now you then turn to, well, you continue this issue about e-learning in the next section. We move on to the problems of changing guidance and keeping up with the changing guidance. And you say in paragraph 23 that the e-learning was never updated.
Yes.
Over what period do you mean by that? I mean, do you mean throughout the whole pandemic or during the first and second lockdown? What?
During the first and second lockdown, it was the same training. E-learning never really changed, so that was pretty much the same throughout, other than the fact that they would maybe add like an additional, one additional module or something to the exact same training. But we did get offered courses for training for COVID-19, but it wasn't mandatory. So it was just whether staff wanted to do it or not. And I chose to do it because I wanted to know a lot more about it and, really be clued up on it all.
And then you say that at some point, I think by implication a little later in the pandemic, a COVID-19 officer was appointed for every shift.
Yeah.
Now, I mean, could that be anyone? Could that have been you, for example, or was there some process by which someone was appointed?
They wouldn't appoint me. I don't know if it was because I was trying to be the union rep that they didn't want me looking at the policies and guidance and procedures and keeping them accountable, but they just appointed anybody randomly on shift. They would just pick a name and say you're the COVID officer for this day. But a lot of the staff didn't know a lot about guidance and policies, and 9 times out of 10 would actually come to me and ask how to update the folder.
And would this officer have done any special training that, or as I say, what I'm trying to get at is, could it have just been anyone from the staff, or was it someone who had a special qualification or had done some extra training or something?
It was just any member of staff. They didn't need any training.
And what was the role of this person? What were they in charge of?
So we had like a guidance folder that would put the current guidelines and policies and procedures in place. It would be about the COVID symptoms, how to deal with COVID, just anything that was coming out new. And they would be in charge of printing them off and putting them in the folder, making sure they're up to date, and just making sure that staff are actually reading up-to-date guidance and policies about, social distancing, family visit members, all this kind of thing.
You go on to say that you yourself undertook some courses in relation to infection prevention and control, I think.
Yes.
Yeah, and did you do that because you wanted to, or you were asked to, or?
I wanted to do that on my own accord, just because I wanted to be clued up on everything that was going on, and make sure that I'm keeping my residents safe, and I could share that information with the staff that I was working with.
Mm-hmm. Now, inevitably, as many others have said, when people got COVID, they went off sick, inevitably, and this led to staff shortages and so on. But you highlight some issues around COVID sick pay.
Yeah.
Yeah.
Yes.
So can you say a bit more about that? Well, first of all, what was COVID sick pay, and then secondly, what were the problems with it?
So in the beginning, you didn't get paid for being off with the COVID, so it was just your standard statutory sick pay, and if that was included, even if you tested positive, you didn't get paid anything. And it wasn't until the union had come about and said that a social care fund had been actually set up that we were advised that you would get full pay if you tested positive, and you could claim it back from the fund. The employer could claim it back from the fund. But I only found out about that from the union. The employer didn't notify us, didn't tell any staff, so I obviously went around and told all the staff about how they were entitled to sick pay if they did get, if they did test positive and have to stay off.
Yes, so as far as the employer was concerned, it was just statutory sick pay. There was no continuing pay for being off sick with a COVID absence, and it depended on public money in the social fund that was set up. Is that right?
Yes, correct.
Yes. And did that continue throughout the pandemic? Did anything change, or?
Obviously, the social care fund that had been set up became more well known, but the employer didn't really implement that and inform staff about that. It was actually me that had told staff about that, and staff went to the employer to inform them that they were entitled to sick pay. They had to fight for it, but some staff members did actually manage to get sick pay whilst they were off.
Well, thank you. You then turn to the issue of, to the issue of testing, and if you tested positive or weren't showing any symptoms, and what the expectations were about being at work or absent. So you yourself, you say in paragraph 27 that you tested positive quite early in the pandemic.
Yes.
Yes,
correct.
but you weren't displaying any symptoms, at least not initially.
No.
And well, what did you do then? Did you stay at home? Did you shield? Did you come to work? And what were the expectations of you?
So I had emailed my manager saying that I wasn't symptomatic, but I had tested positive for COVID. I wasn't entirely sure on the guidance, but I didn't think it was advisable for me to be in work, so I was notifying her that I would probably be off. Then I got an email back saying, well, if you don't have any symptoms, then you are expected to come into work. So I took it upon myself to phone public health myself, and actually ask what the guidance was, because I obviously do not want to go into a care home and spread any. Like, I might not have been symptomatic, but I could have been a carrier. So I wanted to speak to public health about that, and they were like, absolutely under no circumstances should you be going into work. So I had asked them to put that in writing. They sent me an email across, and I had sent that to my manager, and I said I will not be in. Public health have advised that I should not be in, and informed her of the guidance. And then I just got an email back saying, okay.
But then you say that basically you say there was a disconnect between that information from public health and what the expectations of the employer were.
Yes, because the employer was telling us that if we weren't symptomatic that we were to go in, because that was current guidance, but yet that was contrasting with the actual guidance that was available with public health.
And to repeat again, this was quite early in the pandemic that you had these, you tested positive.
Yes.
Or you had these symptoms, yes.
Yes.
Now, you then go on to, of course, a high-profile issue of care homes taking patients who were discharged by hospitals.
Yes.
And you say in paragraph 29, you give your view that you consider that hospitals were prioritised over care homes at this time.
Yes.
And you give your view that for everything it was hospitals first. And then in paragraph 30, you begin explaining what you remember about patients coming into the care home from hospitals. And
yeah.
So what do you want to say about that?
So when patients were coming in from hospitals, they weren't being tested. This wasn't current guidance. So they were being brought into the care home, no testing done, and that had a massive impact on staff and residents. Because when patients were being discharged from the hospital without COVID testing, we didn't know whether they actually were COVID positive or not, because 9 times out of 10 they were coming into the home with a lot of very similar symptoms to COVID-19, which meant that obviously they could be bringing it into the care homes, and we didn't actually have any proof or evidence that they were doing so.
So there must have been space in the care home you worked at for that to happen. I mean, the care home wasn't full then, was it? Or
a few of the residents had passed away, so there ended up being space.
And did this happen quite quickly? If someone passed away and a space became available, then quite quickly afterwards, someone
Very quickly.
Very quickly, someone was received into the care home.
Yes.
Yeah. And did this continue throughout the first lockdown, or was it more true at the beginning or the end, or? It
continued throughout, but when it came to testing, towards the, I would say the second lockdown, towards the end, that's when they obviously they had to start testing people from the hospitals before they were brought in.
And do you remember the incidence of COVID where you worked increasing at this time during March, April 2020?
Yes, I remember a lot of residents being brought in not very well, and then I remember that our death rate just kept going up and up. We would, have residents in the home that would maybe pass away every couple of months, but when these patients started coming in from the hospital, they were passing away in droves. It was like every week, 1, 2, 3 people a week, if that.
And then in paragraph 32, continuing this theme, again, I want you to put it in your own words, but summarising, you describe something like a sort of collapse of regulatory arrangements. I mean, you say that you were entering rooms with positive cases because of lack of staff.
Yes.
Yes. And what you mean by that, I think, is that people were in the rooms, had tested positive, but you were still having to go in there, for example, to deliver meals or what?
Yes, or even just provide care. You can't just leave them just because they're COVID-19 positive, but we weren't fully equipped with PPE to be dealing with people that were COVID positive.
And what you say in paragraph 32 is that some of these people had recently arrived from hospitals.
Yes.
Now, you then go on in paragraph 33 to describe the impact on the health, in particular, the mental health of staff arising from this pressure.
Yes.
And, well, is there anything further you want to specifically say about that subject?
Well, the rate of the death of the residents like passing had massive impact on us all, because we are meant to support people who are on palliative care, and we want to obviously be there at their end of life. We've looked after these people for years, and during COVID and the lack of staff, we weren't actually able to sit with someone that was on palliative care, and because they weren't allowed their family members in, sometimes, you know, a resident might have had to pass away alone, and that's not the kind of care that we wanted to provide. We wanted to be the people that were there at the end of their life, and it was really, really difficult. And I know that had a massive impact on my mental health, and I still think about it and get emotional about talking about it to this day.
And, you know, as you said previously, this was combined with problems of family members visiting, of course, too.
Yes, correct.
Your statement then turns to issues around pregnancy at work and the need for, or the absence of, risk assessments of pregnant workers. And you say that towards the end of the first lockdown, you yourself became pregnant.
Yes.
Yes. And so when you learned you were pregnant, did you ask for any risk assessment in relation to workers who were pregnant?
Yes, so when I became aware that I was pregnant, I obviously informed management and asked them if there was any risk assessments available, because I didn't know the risks of COVID-19 in pregnant women, and I just kept getting, you know, told that there was no time to do a risk assessment at this current moment of time. So I had to kind of keep badgering management and say, you know, it's kind of really important that I get a risk assessment, because, you know, I don't know the implications of what could happen. I want to make sure that I'm following correct, like, health and safety, to make sure I'm protecting myself and the residents. I had actually asked to be furloughed, because I was told that this was happening in hospitals for pregnant women, and I got told no, there wasn't enough staff. Yes.
I mean, you say in paragraph 35 that there was a protocol that a risk assessment should be done. I mean, when you refer to a protocol, do you mean a protocol in the Home's policies, or?
Yes, so I obviously went straight to the policy folder and highlighted the in their contract and in their policy on pregnancy that a risk assessment should be done as soon as the employee notifies management. I brought that highlighted bit of paper in and told management at this point, this is in your own policies and procedures. I would like a risk assessment done, and I think they took it a little bit more seriously because they knew it was their own policy.
Now, we'll turn a little later to what you want to say about your own experience of having a baby during the pandemic. But before we do that, if we just stay with your experience as a worker in this care home, you say in paragraph 36 that you were recommended, naturally, I think, that lighter duties should be taken on while you're pregnant.
Yes.
But this didn't happen, did it?
No, it absolutely did not.
And was that partly because of shortage of staff, or?
I think it was the shortage of staff, but it was also the lack of care from management. I don't think that they prioritised my needs. I think they had a lot more bigger worries that they weren't prioritising any risks that I could have had as a pregnant woman in their home.
And during your pregnancy, your duties continued to include things like hoist lifting?
Yes.
And you weren't limited to staying in the downstairs part of the home, for example?
No, so in my risk assessment, it was advised that I should be upstairs because it was lower risk, because there was less people with dementia upstairs. It was more frail and elderly, and there was usually more staff upstairs, so that I would maybe have a little bit more support. Whereas downstairs was just a little bit more risky because it was a dementia ward. Things were quite unpredictable. There was a couple of residents in there that did hit out quite a bit at staff, so it might have been a bit risky for me to go down there. However, it just kind of went by what suited management on the day, because I did get put between upstairs and downstairs, depending on what staff were in.
And in paragraphs 40 to 42 of your statement, well, specifically in 40 to 42, you do describe some severe impacts on your own mental health from the combination of these experiences. So in the first place, if I understand correctly, in the first place you're pregnant. In the second place, you've got what's going on in the care home, and in the third place, you've got the pressures of work.
Yes.
Yes. So, do you want to say a little bit more about how you felt, how this was impacting you?
So when I was going to work every day, I was starting to have panic attacks, like before I went to work. And then it come to the point where I was actually in work and I would start breaking down, and it was just to the point where I just couldn't do it anymore. I was coming home, I was crying, I was scared because I thought I was putting my baby at risk, but I was also scared because I didn't want to leave the residents I was looking after, and I knew that, you know, I couldn't afford to be off work because I had a mortgage to pay and I was going to be going on maternity leave. So it was really a lot of pressure. I was very depressed and thinking about going to work, and it's quite hard to say, but you know, I would just remember like every morning waking up thinking, I just wish that I would get hit by a bus so that I don't have to go to work. Like I was so depressed that I just didn't want to go in anymore.
And it didn't get any better later in your pregnancy, as you say in paragraph 45, and in fact, quite graphically, you say that you suffered a panic attack one day, I think later in your pregnancy, because of, well, you I think, and one other, you and the nurse were basically alone in charge of 30 residents in the home. So in other words, half the residents of the home.
Yes, there was a lot of staff that were phoning in sick, and the home weren't bringing in agency. One, because they were getting hired in the hospitals and there wasn't enough to go around, but two, they said they couldn't afford to bring in agency in the home. So when I had went in on shift that day, I found out it was me and a nurse upstairs, and I went into panic attack mode because I was like, I can't do this. Not only am I severely pregnant and at risk, we can't provide the care that we want to provide people with that much staff. Like, it's just not possible.
And this is later on, isn't it? I mean, because you say it was later in your pregnancy, so that's like going to be towards the end of 2020, isn't it?
Yes.
And just to be clear about what you said there, was this a problem in finding agency staff, or?
There wasn't a problem in actually finding agency staff. It was whether or not the home wanted to pay for it. There was quite a few agencies out there, but the ones that were available was the agencies that were a little bit more costly, because a lot of other care homes were hiring agency staff as well. So they were tending to find that the only agency staff that were available were the ones that you had to pay higher rates for.
And then in paragraph 46, you do say that you raise these issues. You don't quite say you brought a complaint, but you raise these concerns and specifically that experience that you've just described about more or less being, you know, alone with a nurse in charge of half the residents of the care home, and what you suffered. You raised that with management, and what was the response to that?
So I had sent an email to HR. I'd actually raised it with management, didn't really hear back, so I raised it straight to HR after that. My email was ignored, but then I got a phone call asking for clarification on what had happened, how I was getting on, and I had been telling them about the shortages of staff. I told them that I'd had another panic attack, and I had actually walked out the previous week because I couldn't cope. And and that I was 36 weeks pregnant and I just couldn't do it, and that it was unacceptable, and that I just basically told HR that they need to sort out my annual leave that I'd accumulated for the remainder of my pregnancy, or I would be taken up the tribunal because of how they were discriminating against me for being pregnant. And I had also raised the concern about not being furloughed as well. It wasn't long after that phone call, I think it maybe would have been like 5-10 minutes after, that they were like, "You can finish your shift today." But I obviously said to them, I'm not going to do that to the staff and the residents. I need to make sure that I finish out the week so that they have enough cover. But after this week, I will not. I will go off on maternity.
Now, after you had your baby and you returned to work, in paragraph 47 onwards of your statement, you discuss what you feel are the impacts of the pandemic on the working environment that you were in.
Yes.
Yeah, and that in particular there was a significant staff turnover.
Yes.
Yes, a lot of people left, in other words.
Yes, when I was on maternity leave, I was getting emails from staff, phone calls from staff asking to help write their resignation letters, and I must have 1 week got like 7 messages in 1 week of people resigning.
And after your maternity leave ended, what did you do? Did you return to the care home, or did you leave it to?
So I requested flexible working because at the time I was with my my then partner. He was working full time. I couldn't afford the cost of childcare with just his wage alone, so I wanted to go back to work. I had requested flexible working. They were quite difficult about it, and because of everything that I'd experienced before, I started to feel my anxiety flare up again, and I was like, it's not even worth it, so I decided to resign. I didn't want to return, and then I got asked for a meeting with the new manager who I'd never met before, because a new manager had been hired when I was on maternity. And I told her, she'd asked me to tell her things that had happened before, like in the home, how things worked, and I just went in and told her everything that had been going on and why I didn't want to return, and I just got told, best of luck to you.
Now, eventually you decided to leave and went to work for a public sector care home, is that right?
It's more public and private.
Right.
That I work for, yeah.
Right, and very briefly, you say in paragraph 55 of your statement that, admittedly after the pandemic, your experience is more positive there.
Yes, there was a lot less pressure because I had to go on a 0-hour contract, so I was picking my own shifts around childcare. So it wasn't that I was going in doing 12-hour shifts 4 days a week anymore. It was, I could do a half shift here, a half shift there, pick up when I could around childcare.
All right, well, thank you for that. Well, earlier I said that we would turn to something else, which was your own experience of maternity services during the pandemic when you had your baby. So you say you found out you were pregnant towards the end of the first lockdown, that's in paragraph 56 onwards.
Yes.
And you gave birth sort of around this, early in the third lockdown, I think. But you say in paragraph 57 that the maternity experience, in your own words, was absolutely horrendous.
Yes.
Yes. So do you want to say a little bit more about that then? So when did your experiences with the maternity services begin? Obviously, you became pregnant. You knew you were pregnant in June 2020. But when did you start to have your visits to the maternity service?
So there was a bit of a lack of visits with maternity, so that was one thing that I think was pretty bad, and because it was my first pregnancy as well, so I didn't really know what I was doing, didn't feel like I had the adequate support. I was going to scans on my own, and then the maternity services, in terms of what I'm talking about, is after I actually had my child, I did not get the support that I needed. I was going to be, I was trying to breastfeed. During the pandemic, there wasn't actually any services available on how to breastfeed. You could normally attend classes and that before the pandemic. There was nothing like that. There was no online classes or anything that I could have attended. So I kind of really struggled with breastfeeding after, because I had a C-section. So trying to ask for support from maternity services on me breastfeeding was really, really difficult. And the hospitals and the health visitors, there was a severe lack of it. So I was really struggling. So I'd actually contacted a volunteer service, breastfeeding support, like cafe in my area. And if it wasn't for that service being available, who are actually volunteers, I don't think I would have been able to breastfeed. And I ended up breastfeeding for 2 years. So that service was absolutely amazing. But I feel like that service should have been available from the hospital and from the staff. It just wasn't there. And also, I dealt with postpartum anxiety and depression, and I didn't get any support with that whatsoever.
But you also describe your the period of labour as being very difficult while in the hospital. It was long and difficult.
Yes, so I was in the hospital for 10 days. I'd probably say it was the worst experience of my life, because we weren't allowed to go outside in those 10 days. So no fresh air for 10 days was absolutely horrendous. We weren't allowed to leave the rooms. We were stuck inside the room for the first 6 days whilst I tried to have an actual birth. We weren't allowed to go walking about the hospital or anything like that. We weren't allowed visitors. If my partner at the time wanted to leave the hospital, he was told that he wouldn't be allowed back in. So he couldn't leave to go and get like any food or anything like that. If we needed new clothes, family had to come to the door, drop off the clothes, and then the staff would go downstairs, pick it up and bring it up to us. I think it got to the point where, like, after I'd had my little girl, after my section, one of the porters, or the janitors, I can't remember the name of the staff, he had actually came to take me for one of my MRI scans. And I remember being so excited because he went the long way around the hospital, so I could actually see air and other people. I just felt like I was losing my mind. And I think when you're so vulnerable after you've just given birth, I really think that had a massive impact on me.
And you say towards the end of this section that postnatal care was, in your opinion, poor.
It was very poor. They didn't. You could tell the staff was under pressure. You could tell that they were short-staffed. You could tell that they were being run into the ground. And as a care worker, I get it. I understood how they felt. But as a patient, I felt neglected, and I felt like my needs or anything that I needed to ask them wasn't prioritised. They didn't really have a person-centred care. It was just as quick as they could get in and get out.
You don't expressly deal with this in your statement, but what do you want to say about care after you left the hospital? For example, health visiting services, children's visiting services?
So that was really difficult. I barely seen a health visitor. I actually had to contact the health visitor in order to ask when they were going to be coming out to see my little girl, because obviously her development was really important to me, and I wasn't getting her weighed. I wasn't getting, like, they weren't coming out to tell me anything. I was a first-time mum, so I didn't really have any experience of how it was meant to work before. But I know from my sister giving birth previously that she's seen a health visitor quite regularly after she gave birth. And I've maybe seen her once, twice, maybe even 3 times through my aftercare.
And this would be during the third lockdown in the first part of 2021?
Yes. But it also continued. Like, it was up to me to be able to contact the services, not the other way around.
Well, thank you. You then turn finally to the lessons you would like to think will be learned from what you've described. And I suppose there are 2 parts to this. There's the lessons to be learned from what you've been saying about your experience as a care worker in a care home, and then secondly, the lessons to be learned from what you've just described about maternity services. So if you want to deal with the first one first, I mean, what would you hope would be the lessons that will be learned?
Well, I'm really hoping that when the government are doing the National Care Service and they're introducing fair work, that they're going to hold private care homes accountable. And what I mean by this is I think that they need to start listening to staff that are on the floor rather than the people who own these private care companies. I think it's important for care workers to be able to share their experiences in order to be able to actually improve policies and procedures in the future. I think that involvement with trade unions is really, really important in care homes because no one's holding private care companies accountable at the moment. And I think that the care workers need a voice and they need someone to hear them. Regardless of who the union is in it, I think it's important that they have someone to advocate for them because a lot of staff aren't aware of their rights. And if it wasn't for me knowing my rights already, I probably would have been treated a lot worse than what I already was. So I think that it's really important if we're going to introduce a national care service and a fair work scheme that we actually have fair work procedures put in place and the government really, really learn from the mistakes that was made. And I also think, sorry, just to add in, that all of these COVID inquiries and people like me talking, it's really good that the public can hear how transparent we're being because they didn't actually know a lot of what actually went on in the care homes. So it's good to hear from people like me and people who worked in the care homes because they can see what actually went on.
I mean, you do say in paragraph 67 that you think that especially in terms of not following correct procedures. I mean, you have referred to protocols and a handbook of procedures and so on, but I mean, is the implication from that, what you want to say is that yes, there were procedures and guidance books and so on, but I think you said once you had to go and look at it yourself and the book's there, but there's a difference between the guidance book and the protocols being in place and actually being followed. Is that what you're saying?
Yes, correct. I mean, I was a union rep, so I kind of knew what I was doing and talking about. But what about people who don't have a union rep in the care homes? Like, how do care home providers be held accountable for following these policies and procedures if there's no one there to help them be accountable? It's down to the government to make sure that they are following correct procedures and policies and protocols and make sure they are held accountable if they don't.
And is there anything specifically you want to say about lessons to be learned from what you experienced in relation to maternity services?
I think, you know, a lot of the hospital staff are actually the same. We have the same experiences with them as in the care homes in terms of they're absolutely run into the ground. So I think there needs a lot more mental health support in the hospitals. I think that there needs to be a lot more training in terms of aftercare when it comes to maternity services. I definitely think there needs to be better training when it comes to breastfeeding and more services provided for mothers who haven't breastfed before. And yeah, I just think that that the government need to be looking at how care is provided in hospital after birth, because it's just so important when someone's so vulnerable that they get person-centred care rather than just treated like a number.
Yes, well, thank you very much. Is there anything else you would like to say to the inquiry?
I think I've said most of what I wanted to say in my statement, and today I just hope that, you know, that lessons can be learned from this, and I hope that there is positive change when it comes to private care homes, because I feel like we have been forgotten for quite a bit now, and it's time that care was prioritised, social care was prioritised as much as the hospitals are.
Well, thank you for your evidence and the effort you've put in both today and to your statement. Once again, thank you. My Lord, that concludes the evidence of this witness.
Yes, thank you very much indeed. And can I just thank the witness very much? Very good. 12:30, I think you're taking the next witness. 1:30, I should say. I think you're taking the next witness, Mr. Edwards.
Yes.
Yes. Okay, thank you. Very good.
Thank you both.
Thank you.